getting up early.
All right, everybody, let's get started. It's a couple minutes after. I know we're going to still have some people signing in, but we got to get the ball rolling here. We've got a busy day. So welcome, everybody. I hope everybody's doing well. It's good to see all your faces. Let's start out with the Pledge of Allegiance.
Okay, hold on 1 second.
Okay.
The flag is going to appear, right? Get my sound off.
There you go.
All right. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right. Dick, would you be willing to give our invocation today?
Sure, am I on?
Okay.
Dear Heavenly Father, creator of all things good, you know better than anyone that we're in a heap of trouble these days. We would ask for your wisdom, for your support. Help us through the difficult times, dealing with the COVID, dealing with the political situation. Continue to watch over our president and his wife. We wish them well. We wish them wisdom. We wish them conversion. Bless us now in our ability to help our community in which we live, which we are privileged to live. Thank you for all the blessings. In the name of your Son, amen.
I can't open.
All right. So, guest today, Aaron, it's good to see you. Welcome. Thank you for being our speaker today.
Thank you. Can you hear me okay?
Yes, we can.
Perfect.
All right. I don't see any other guests aside from our esteemed Lieutenant Governor Steve Emhoff. Thank you for joining us.
Thank you for inviting me.
Okay, so let's go right into announcements. Who's got our first announcement today?
I have a couple.
Okay.
First of all, the food bags, I hope that those people who have them have filled them up. And we would like to pick them up on Friday at 10 to 11 at Centennial Park, or Saturday 10 to 11 at Centennial Park. If you cannot make either one of those and you need somebody to come and pick it up, just give me a call and I will be glad to do that. The other thing I'd like to, in regards to the bag, I really need to know who has them. So when you drop off your bag, if we could get a list of the people who are actually dropping them off. And if you want another bag, let me know and I'll make sure that I get it to you, okay? The other thing is, I got a call yesterday from some folks in Bend who are closing down one of their stores, one of their offices, and they have a lot of furniture that they'd like to give away to a charity of some kind. Somebody could use it. So if you know of some organization who needs things like a desk, a chair, things that you can store equipment on or whatever, let me know. And I will see what they have. I'm going over tomorrow to take pictures of the stuff they have. And that they would like to donate it to some kind of charity, to some kind of 501c3 organization. Because if they don't, they have to, by company policy, take it to the dump, which I don't think is a good idea. So if you can do that, I greatly appreciate it. Thank you.
Does the Redmond Learning Center need anything?
I was over there this morning and we're going to look and see what they can have. Might need a desk, might need some storage units, but they need to see what it is first. Thank you.
I have an announcement.
All right.
The St. Thomas Academy will be dedicating their new playground Friday at 2:45 p.m. Our foundation was the largest single contributor to that project with a $6,000 check, and it's a $100,000 project. So if you're available Friday at 2:45, it promises to be a short ceremony.
Okay.
I'll be there, Carl.
I will too.
Carl, how are things going with the Vintner Dinner online auction? Do you still have that one item remaining?
I have closed all the items, and Nikki Lardo got the Sheraton Hotel, so all accomplished. We'll have some checks to deposit pretty soon.
Okay. All right. Perfect. Yes, Amber, you're on mute.
Thank you. Good afternoon. This month I'm sponsoring Redmond Cares. It was a program that was started by RPA. They collect non-perishable items for the community, and then on Fridays they deliver them out to families that need them. And so if you're interested in donating or would like a list, please feel free to email me or let me know, and I can email you a list of items that are needed. And then drop-off location is at the Umpqua in Redmond on Tuesday, Wednesday, and Thursdays from 1 to 4, or I can come pick up if you need me to do that too. I'm more than happy to.
Perfect. All right. So anybody else? All right, I've got just a couple. Kiwanis International has extended its new member promotion. So no new member fees for the balance of this calendar year. So if you know somebody who is considering joining, if they are a member before December 31st, they pay no dues until October 2021. So now is the time. So spread the word. Also, we're going to have a special board meeting today immediately following this meeting. So any board members, if you can, please stay on the call once we're done. And all right, so joke of the day. My dad got me with this one. He said, "Did you hear the news? FedEx and UPS are merging. They're going to be called Fed Up from now on." All right, so time for our program today. Aaron, please take it away.
Thank you. Just real quick question for you, Rachel. Can I share my screen? Actually, I think you need
Yes, just a sec, I'll get it for you.
Yeah, we'll get you permission here in just a minute.
Okay, you're good.
All right. Let me see. Can you guys see that okay?
Yep.
Yes.
Excellent. So maybe, I haven't had a chance to meet everyone I see on the line here. I've met a few of you. For those of you who don't know me, my name is Aaron Adams. I'm the president for the Bend and the Redmond hospitals here at St. Charles. I actually came to Central Oregon and joined St. Charles back in early 2018. Prior to that, I lived in Northern California, and I worked at an organization called Sutter Health. Worked there for about 17 years in various hospital leadership roles, and was fortunate to be asked to come up here and be part of the St. Charles organization. So I appreciate you guys having me today. Hopefully over the next year or so, I'll get a chance to meet more of you and engage with more of you. So again, I thank you for having me. The reason why we were asked to come today, and I think what we're hoping to accomplish with our presentation today, is really just to share with you some of the thinking we have going on around the Redmond Hospital. Back in January, we had a Redmond visioning session where we brought different community members, different physicians, different St. Charles folks together for a half-day session to really talk about what Redmond, that hospital, could become in the future and what some of the options might look like, and had a lot of dialogue with those teams. And so I wanted to share with you a little bit about what we talked about and what some of the feedback was from the community and the people who participated in that event, and how we've really been using that information to think about different pathways we could pursue when it comes to, I think, slating a course for Redmond over the next decade or two, as we think about its role both within Central Oregon and within the St. Charles system. And then again, I would love to get your feedback today on what we share and get your thoughts. One thing I just ask you to keep in mind, I think our goal is to try to share this, even though we're right in the, I would call we're in the making sausage phase. We're talking a lot about a number of ideas. We haven't implemented any of these ideas yet. We haven't entered into any commitments yet around them. So we're really trying to share and get input and feedback while the sausage is being made here. So just ask you to keep that in mind. So maybe just make sure you guys see what I see here. Do you see the hospital, the slide with the hospital picture on it?
Yep.
Okay, perfect. So why would we host a Redmond visioning session? Well, what problem were we trying to solve, or what opportunity were we trying to take advantage of? There's really a couple of challenges that we have with the Redmond facility. Well, the first thing, from a positive perspective, it's a very, if you've spent any time there, right away, it's a very relaxed, warm care setting, especially for a hospital. Has a really great feel to it. It's very therapeutic. We have a very passionate set of providers and caregivers that work there. They're very passionate about the organization. They provide a lot of really wonderful services. So it's a great facility, but it has a couple of challenges. The first is it's not fully utilized. If we look at just the number of beds that we have available, we're licensed for 48 beds. Our census generally runs somewhere around the neighborhood of about 22 patients a day. So we're less than half utilized when it comes to our inpatient bed capacity. And then our operating rooms, we have 4 operating rooms and a fifth, what we call a procedure room. And the 4th and 5th rooms aren't ever really utilized, and the first 3 are utilized about half the time as well. So we have a lot of unused capacity there. And being such a really wonderful facility, we wanted to talk about how do we better utilize or fully utilize the assets that we have there in Redmond. Just to give you a feel for what would be considered normal, usually you're looking at you want your occupancy to be right around that 80% mark. That means you're fully utilized, but you have flexibility on days when you're running fuller than your average to be able to accommodate spikes in your census. So we're just a little more than halfway what we'd like to see, I think. The other issue that's brought up often to me by providers, physicians, and caregivers is, what role does the Redmond Hospital fill within the St. Charles system? Is there a unique role for the hospital to fill? What role does it fill when we think about the broader region, the Central Oregon, and what makes it unique and what's going to be uniquely ours here in this community? So those are a couple things that we really wanted to engage the teams in discussing. And so we spent about 4 hours together, and we really talked about 4 possible pathways forward. One was, what if we just didn't do anything? We just kept everything the same. We didn't worry about addressing any of those issues. The second was, what if we were able to get aligned with some individual physician groups to actually feature a particular service line there in Redmond, like a total joints program around orthopedics? What if we took a different direction and we moved away from being a general acute care facility and we became more of a specialty hospital that focused on things such as becoming such a thing as a surgical hospital, which is a little different than a general acute facility. It's really a place where you go and you get your elective procedures done. And then the fourth was, well, what if we went in a totally different direction and we actually became a post-acute facility where we took care of people post-hospital discharge? So inpatient rehab, skilled nursing, hospice care. There's a number of services that exist after someone leaves the hospital where we have a lot of access challenges in our community, and can Redmond help us fill those? So these are kind of the rankings that people gave us on those. You can see this is what people were willing to support and what they weren't willing to support, but this was really their ranking here. So out of those options, what did they rank really as their first choice? And about 85% of the people said, well, I think either featuring a service line or helping solve some of our post-acute challenges, those would be our number 1 and 2 choices if we had to choose between this list. And if I had to put it into some main themes that we heard from people, it was, we support track 2 and track 4 as kind of our premium choice. If we pursue track 4, we don't want to jeopardize our general acute care status. So can we help solve some of the post-acute challenges in the community without jeopardizing our general acute care status? is there a service that could be provided uniquely in Redmond that wasn't being provided anywhere else to really help us think about a unique identity to the community? And then the last was they had a really good time, I think, having the opportunity to give input and feedback. So the feedback from the community was just keep engaging us in this kind of dialogue. And so a few weeks ago, we had a follow-up session with that group where we provided the update that I think you're seeing here today. We're obviously sharing this with you as well, and we shared this at the chamber about a week ago as well. So we're trying to take that feedback. So here's what we've been doing with that information. Now, this happened before the pandemic. So we started to, do our analysis and follow up post the visioning session. We got delayed a little bit, obviously, with the pandemic happening, but this is our current thinking right now. The first is really, to me, is around inpatient rehab. This is I don't know how many of you are familiar with inpatient rehab, but when somebody gets discharged from the hospital and they can't really go home yet, they need some type of acute level rehabilitation where they actually need to be checked into the hospital. That's what inpatient rehab does. If you kind of see the different conditions that they care for, people who've had strokes, spinal cord injuries, major brain traumas, severe burns, amputations, things that like. So these are people with really serious conditions that getting into a rehab program makes a difference as to whether or not what their quality of life is going to look like once they get discharged from the hospital. So it makes a big difference. And so we know when people actually take advantage of this type of service versus going home or doing skilled nursing, they tend to get superior results. So these are really, again, what I would call high acuity level patients. So one of our thoughts is, could we expand the Redmond program the rehab program at Redmond? So today there's a 12-bed unit at Bend. It has a census of about 11.5. So it's running somewhere around 92 to 95% full all of the time. So we have access challenges in getting into that program. If we were to move it from Bend to Redmond, could we grow the size of that program and in order to accommodate what the community access needs are? So as you can imagine, with that level of occupancy, we have a lot of access problems today with only the 12 beds. Not only do people sit in the hospital longer before they can get into the program, but there's a number of different types of services that you would see on this list that we're not really taking care of in our location because we just can't get them in. So we do a lot of stroke patients, but many patients who fit into these other areas, the bullets below that, they tend to either go without care, go to skilled nursing, or they have to leave the area to get care because we're full. And that access problem for our community is going to grow. Today, about 85% of the people who receive care in our current program are over the age of 55. And if you take a look at our list here and look at growth in that population segment from 2020 to 2040, we anticipate that those demographics to actually double in size over the next 20 years. So whatever problems we have today are going to grow significantly. And we have a really wonderful program today, other than the access challenges. We're in the 99th percentile for patient experience in the entire country. I've never worked anywhere where I think someone has had that high of a patient experience score. And you could see some of the other statistics here that I think really show that this is a top level program that we're providing. If we were to move this to Redmond, our occupancy at Redmond would go up to, would land in that 70 to 80% range. So we'd see about another 18 to 24 patients a day in the Redmond location. And it would bring somewhere in the neighborhood of about a little over $26 million in revenue to the Redmond community. So pretty big pickup financially. So lots of opportunities there. The Redmond campus also has a really wonderful outdoor areas behind the hospital, which would allow us to do some outdoor rehabilitation activities, which is always very therapeutic for people to be able to go outside as part of their therapy and not just be stuck inside the hospital or some type of indoor gym space. So this is one of the major moves that we're thinking about. If we were to think about bringing a service line to Redmond, one of the challenges we have at St. Charles is most of the surgical specialties live within independent organizations. St. Charles generally does not have a lot of surgeons. We have some cardiovascular surgeons and we have some general surgeons that already practice at Redmond. Orthopedics, GI, urology, all of those are independent groups that are separate from our organization. So to get them to bring their types of services to Redmond and to feature it there, they would have to choose to engage in that type of partnership. And that's one of the challenges that I think the hospital administration has really faced over the last 20 years is most of the independent groups struggle to do that. They have elective practices, clinic, they're generally running those things in multiple communities. And to actually provide surgeries at multiple campuses becomes very difficult for them to manage. So we tend to struggle to get that type of commitment and partnership. But St. Charles does have a general surgery practice, and we do have 5 general surgeons that are practicing in the northern campuses today. And we do believe that we can grow that. We know that there's a couple hundred patients that live in the north today, Redmond, Prineville, Madras, Sisters, Warm Springs, and they receive some type of general surgical care, but they go all the way down to Bend to get that care. And we believe we can keep that care in the north and we can care for those patients at Redmond. So many of you may have heard that we recently added a Vinci Robot. So we've introduced robotics on the campus there at Redmond. That's really important part of general surgical practice in order to attract physicians in their business there. Allows us to do more procedures there that we couldn't have done there in the past. So one of the other things we're going to do, regardless of what path we take, is really an asserted effort around growing the general surgery there in the Redmond facility. I assume, Rachel, you just want me to kind of move through and then we'll stop and do questions at the end? Okay, I know this is a lot of information, so I apologize. The other thing that's come up, and probably many of you have heard this because I know there's a lot of conversation around the community, is there's 2 independent orthopedic surgical medical groups in our community, Desert Orthopedics and the Center. They came to the hospital basically with a proposal to start what we call an orthopedics trauma service. So we do already today have a general surgery trauma service. So when someone has a serious injury that doesn't impact, let's say a bone break, they have a complex injury of some type, they come to our trauma program, our dedicated trauma program here at Bend. But we don't really have that for orthopedics. So these groups were really recommending to us that we develop an orthopedic trauma program centralized at the Bend campus. There are some implications to Redmond if we were to choose to do this. The main features of the program are basically creating a dedicated trauma room at Bend where we would have a dedicated surgical team every day manning that room, regardless if anybody had any scheduled cases or not. And that room and that team would be fully dedicated to handling any traumas that occur and actually handling them in the moment. One of the main challenges we have today is you have doctors who are on call and other things and teams that are on call. So you might have a patient present at Madras and they may make multiple stops before they get to a trauma room, let's say in Redmond or Bend, and they actually get the care that they need. And it may take several hours in order for that to happen. Having this dedicated team and this dedicated trauma room would help us to solve some of that. It does have some implications for Redmond in particular. It would mean that all of these trauma cases that involve orthopedics would be centralized onto the Bend campus. Today, we do, there are about 22 types of cases a week that occur of this type. 11 of them present at Bend and 11 of them present at the northern campuses. So someone shows up in the ED at Prineville, Madras, or Redmond. About 4 of those a week are currently handled at Redmond. The other 16, 17 are handled at Bend today. So it would mean that about 4 cases a week would move from Redmond to Bend, and it would change the trauma designation at Redmond. There's different trauma designations. Prineville and Madras are level 4, Redmond is a level 3, and Bend is a level 2. In order to qualify to be a level 3, you have to provide orthopedic trauma services. And so if we did move the orthopedic trauma and we centralized it at a single location, it would mean that Redmond would become a level 4 trauma center. That's all it would mean. We would still be providing elective orthopedics there. So if you needed to schedule a knee replacement or a hip replacement and your doctor is Dr. Hombo, he would still do that work at Redmond. This is really somebody who's in a car accident, has a major fracture. They would just go right to this trauma room. So why would we do this? Or why would a hospital team consider doing this and accepting this proposal? For me, there's a couple things from a patient perspective. One, I think it gets patients in the OR and gets their intervention to occur more quickly. So after serious trauma and serious injuries, you really don't want any delay in care. And so I think having this dedicated team in this dedicated room really helps us get those interventions in place much quicker. It also ensures at Bend, one of the things that you have is you have the general trauma team. So if you have multiple injuries, let's say you have a spleen and a broken leg, you've actually got the general trauma service there, and you have higher level wraparound services. So cardiology and other types of things that are in neurology and other types of things that are on site. And the services at Bend tend to get the patients home sooner. So once you do have your surgical procedures, you tend to get home sooner when you're at Bend. And we think with this dedicated program, you'd actually be able to get people home even sooner. It's not unusual to have patients stay in Redmond extra days simply because of how the docs rotate. There's a couple of programmatic problems as well that we're dealing with. Usually in order to have a call coverage at a hospital, you need at least 4 surgeons to split up call services. We only have 2 orthopedic surgeons that practice in Redmond today. So there's Dr. Hombo and there's Dr. Gingold. They do those services there currently. And Dr. Hombo is going to retire he's less than a year from his retirement date, which I think is next fall. So we're going to be down to 1 local surgeon. So one of the challenges we have is we find ourselves trying to pay Bend orthopedic surgeons to come provide call at Redmond. And basically part of their proposal was them telling us, we can't do that anymore. We're providing call at Bend. We're running our elective practices. We're running our clinics. I can't keep going to Redmond to provide coverage for you. And you need the Redmond docs to do that. And there's not Redmond docs there to do it. So it's one of the coverage issues that we have. And what tends to happen is when we're providing orthopedic call at Bend and Redmond, it's not unusual for the orthopedic medical groups to have the same doctor on call at both locations, which is actually frowned upon from a trauma compliance perspective. And so what that does is, for me as an administrator, it puts my program at risk from a regulatory perspective. And so part of this question too is, the physicians, and part of the reason why the physicians brought this proposal forward was, they're suffering from burnout and they're not wanting to continue to operate under the existing model. They feel that they're going to start to lose surgeons from the community. We recently had 1 orthopedic surgeon leave the community, and part of it is them trying to manage all the complexity of providing this type of service at multiple campuses. There's other things that contribute to that, but that is part of it. So we haven't entered into any agreements here. We're doing some pilot work around this. We're talking to some of our partners, but when I think about it when I talk with folks, clinicians and others, there appears to be pretty good consensus that this might be better from a patient perspective. And it certainly solves a number of programmatic problems we have based on the structure and size of Redmond today. So those are some of the reasons why we're thinking about that. Time check, 3 more minutes. We doing okay, Rachel? Okay. So to me, this next thing that we're thinking about, to me, is the thing that's going to make Redmond thrive in the long run. And this is considering adding a medical office building to the campus there in Redmond. So we do have medical practices throughout the Redmond community. They're scattered in different buildings. And so we're finding that we're having some space issues and some space challenges in different places. So one of the thoughts is us creating a multi-specialty medical office building there on the Redmond campus. One of the things that would allow us to do is not just centralize all of the physician practices there in a single location to make it more convenient for people in the community. It would allow us to add space for other specialties. So could we have urology up there? Could we have a post-stroke follow-up clinic? could we have other orthopedic surgeons practicing up there? So part of what I think we're hoping is by starting to embed specialties there in the community that do their clinic in the community, that they'll actually want to see their patients in the community. So one of the things that happens now, there's a Desert Orthopedics and there's a center building there in Redmond, but those are really, with the exception of Gingold and Humboldt, those are really Bend-based physicians coming up and running clinic in Redmond and then bringing those patients back to Bend to perform their surgeries. I think what we're wanting to do is let's get some surgeons who are based in Redmond that are doing their clinic in Redmond and then doing their surgical procedures either at the hospital, or should this facility also have an ambulatory surgery center? So if it's a procedure that doesn't have to be done in the hospital setting, like an endoscopy or some type of colonoscopy, we could do those procedures in this facility. But what it means is we wouldn't have doctors coming up and running clinic in the North campuses and taking all the business back to Bend. That would, in the long run, I think, help the hospital thrive and grow there. I think it helps improve the sustainability of that program. And the same is true for cancer services. So today, we do provide medical oncology there in Redmond, but it's full. You know, the building that we have is completely full. So there's still a number of patients that live in the north areas that have to go, they either get service there in Redmond, but many of them still have to go all the way down to Bend to get service because that's where we have the capacity to treat them. And right now, all radiation oncology patients have to go to Bend in order to get that care. And so one of our thoughts is if we can create a comprehensive cancer center in there, we can create more room for medical oncology. We can add radiation oncology to the community, and we can keep those services there in Redmond, and that could really be the hub for that care in the north. Just to give you an idea, some of the numbers that would add, just cancer services would add about 1,300 office visits, over 6,000 treatments to the community. It'd add about another $10 million in net revenue to the Redmond community. That doesn't even include any of the additional specialties we might add as part of the MOB or as part of the surgery center. So to me, I think this investment really sets the foundation, I think, for the financial stability and robust use of that Redmond campus so that we can continue to make investments in the hospital and we can continue to utilize it to a greater degree. This is something we're looking at doing. We do have to do a bond financing if we do this. So we are looking at what it would take to issue bonds in order to fund this type of a program. So those are some of the things that are on our radar. So what would this mean for Redmond in the future? So if we looked up in 3 to 5 years, you know, the Redmond Hospital and the broader campus, if we were to pursue these options, would be a much, much busier place. It certainly would be far better utilized. And it would mean a pretty significant investment or increase in the economics for Redmond. If you just look at what you saw there, even with some of the cases moving to Bend for orthotrauma, it's still a $30+ million pickup in net revenues for the community. It would mean likely hundreds of new jobs in the community. We would certainly expand access to both the community and the region around rehab services. The medical office building would give us a lot of flexibility and a lot of foundation for building and growing in the future. And if we did move rehab services there, that would be the only place that it was being provided. And I do think we have the ability to create a destination service there, a really top echelon service for the region. So it would really serve as kind of a unique feature of that campus. So I think something that the community could be proud of. But those are the things that are on our mind. Like I said, we're still making sausage and we're still getting input and feedback from people. I would love to hear your thoughts and answer any questions you might have. I know that was a lot of info.
Got a question. This is Roland. Mm-hmm. Any of these plans preclude some need to transport people to Portland hospitals?
Well, it could. Today, we believe that there's a certain percentage of patients that need to get into rehab, inpatient rehab, that aren't able to get in a timely basis today. So some of the brain injuries, some of the spinal cord patients, they're likely being shipped or seeking service in the Portland area, and we could keep those in our community. We think there's actually several hundred people from that rehab program that are not getting services in the program today, but probably should.
Okay, this is Ann Graham. I used to be a city councilor 4 years ago, and we came very close to passing a bond and building a medical office district around your hospital and with your hospital's engagement. I just wanted to be sure, all these plans sound wonderful. It sounds like if you could create a specialty destination that would bring other kinds of clinics and providers and even manufacturing companies who make items that would work in that medical specialty to Redmond, it fits right in that plan. So I wanted to be clear that you're still working with the city at some level.
I think our goal is to figure out, can we finance something like that? And then if we can, we would re-engage with George Endicott and the planning team there, Chuck and everybody. Yep. We need to make sure we can finance it first, and then I think we would engage in that conversation. But we should know that in just a couple of weeks.
And the city, you aren't going to ask the city to participate in the financing because the city obviously benefits.
Well, I could talk to our CFO about that. That's a good question.
Okay. Well, I love the presentation, love the detail. Thank you.
And again, we don't know exactly what we're going to move forward with and what we're not. We're still exploring some of them. You know, I was feeling really good about the rehab program up until just a couple of weeks ago. Part of my challenge there is, can it fit? You know, if we put it there, I'm actually feeling like, you know, there's so much opportunity for that facility to grow. I also don't want to crowd out the services that exist there today. So, you know, there's just little nuances like that for us to figure out and make sure that we don't make any missteps. But this is our current thinking of where we think we have the biggest opportunity.
Appreciate it. Thank you.
Can I just ask a practical question? Let's say I've got a son who breaks his foot, which is not out of the realm of possibility. And I go to St. Charles, Redmond, not knowing that you don't handle trauma. Do I turn around, put him back in the car and drive to Bend, or is he going to be ambulanced to Bend? And if so, isn't that additional cost to the patient?
Yeah, those are really good questions. So likely under this model, you would get moved to Bend. I think if you checked into the ED there and you were stabilized, yes, likely you would have an ambulance ride there. We are looking at how the transportation costs would be managed and whether that's something that the health system is responsible for or whether that would go back to the patient. One of the main thing that we think would be beneficial from a financial affordability perspective for patients is on average, it appears you would go home at least a day, if not maybe 2 days earlier if you went to Bend, depending on which day you presented in that ED. And so a night in the hospital is far more expensive than an ambulance ride. So even if you did incur transportation costs as part of that, let's say that's where we landed on that, getting you home a day earlier would actually make the visit more affordable for you. So those are the things we kind of have to weigh in there. And I think part of our meetings this week with some of the city partners around how we transport people and how we do inter-facility transfers. Right now, they've had the right of first refusal to take those patients, but it may turn out that we can start to provide those inter-facility transfers. And if we do that, that would also allow us to keep those transportation costs off the patient. So we're just starting those conversations this week with those partners.
This may not be relevant, but does dropping from going from level 3 to level 4 impact how Redmond is Redmond St. Charles utilized in the case of that earthquake off the coast?
We had our licensing team's been looking at that. So far, they've told us that's fine. It's okay. It's not really going to impact that. But I personally have not spent a lot of time on that. They did that work, but no one seemed to think that would impact our situation there.
Erin, this is Michelle Duff. Do any of the health systems in Central Oregon have an infectious disease program?
All of the most all hospitals have to have an infectious disease program.
Okay, I was thinking primarily. I was thinking of the Ashland Hospital, Oregon Hospital has had a COVID or infectious disease program that the Medford hospitals ship the patients to. And I was wondering if we have something similar here in Central Oregon.
Yeah, for COVID patients, we do.
Okay.
Right now, what we've been doing is we have a special unit set up here at the Bend Hospital. So if a patient presents at any of the facilities, if they need to be admitted, well, first they get tested. If they need to be admitted, then they're shipped to Bend. And then they go into that unit. And part of what we're trying to do by doing that, there's really 2 or 3 main advantages to that. One is it allows us to cohort those patients together, because one of the big issues that happened early on, as you're aware, is if the workforce gets exposed and you end up getting a sick workforce, it immobilize your ability to take care of the community. So by cohorting these patients and having backup and redundancy on that staff, you eliminate the chance of having a major outbreak in your teams. The second is, one of the things that we realized is even when somebody has mild symptoms at the beginning, it's not unusual for them to all of a sudden become very severe and need an ICU level of care. So by having them here at Bend, we can escalate them to the ICU here in very, very short order versus, okay, they've taken a turn for the worse, they're in Madras and I've got to get them to Bend now, and they've got to spend an hour doing a transport there that they probably shouldn't be undertaking. So that's how we're handling it currently. The volumes are relatively low right now, just to give you a little background. So we have about 6 to 8 patients at most a day. It's been a little bit less than that at times. So we have seen the volumes come down in the hospital, even during those weeks when the number of active cases in the community have appeared to go up. And we've gone up to 400 plus active cases, and we've gone down into the high 200s in the Tri-County area. But our census internally, our admissions internally related to COVID have been pretty stable, regardless of that change from week to week. But we do anticipate that picking up going into the fall here as the weather turns. So we're prepared for that.
Hey, Aaron, this is Chris Ritchie. Thank you for your presentation. One of the questions that hits closer to home for my family is childbirth. And I know that a couple of years ago, the birthing center here in Redmond closed. And it sounded like that was they were being underutilized. And I just didn't know if you've seen some of those statistics where it's, increased utilization and therefore reducing costs. And I know you may not be prepared to speak on that, but I wanted to throw it out to see if you had any comments on that.
Yeah, I'd say at the end of 2019, we saw that the overall just births were up slightly. They flattened out a bit this year. Of course, birthing mothers, it doesn't really matter if there's a pandemic, they come to the hospital regardless, right? So, oops, I lost you guys there. There you go. And we have seen some improvement in our cost structure because of it. I think we've been able to get the cost per birth down. We've been able to get our labor costs down around it. All of the folks that worked at Redmond that had been part of that program earlier were all placed in different positions and jobs. So we were able to keep the workforce at Redmond intact. Some of them went into the OR. Some of them went into the ICU at Redmond. So we've seen a number of the benefits of that. We certainly have seen our safety scores go up a lot. We've seen the redundancy in our systems to be able to handle complex cases improve quite a bit. And if you really think about it from the clinician standpoint, that's what they really cared about, is what happens when somebody has a complex case that needs to be managed, and having those patients next to the ICU has been helpful. I think with COVID too, it's actually helped us solidify our testing and managing those patients, because sometimes you do have moms that are positive when they're coming in to give birth, and that adds some issues with the NICU and things. So I think we felt pretty good about that, other than the fact that, we sure wish we would have done a better job with how we communicated and engaged the community in that work. But other than that, I think it's worked out for the most part.
Aaron, I had a question. This is Josh Werner. As the others have said, thank you so much for coming and speaking to us. The presentation was great. My question is about the focus group that was polled. How were those folks selected, or did they come to the hospital and say, we've got opinions we would like to voice? And then how did that process look? And how, I guess the main question is, how as a community member can we get involved in those kind of decisions moving forward?
Yeah, those are excellent questions. So I don't know how many of you know Lisa Doby. Lisa was our philanthropic executive here at the St. Charles Foundation. She manages all the community outreach. So when we wanted to put the visioning session together, we just engaged her and asked her to engage community members. We had asked her to kind of go through the different community organizations and try to invite a few people from each of those groups. So we had a wide array of people participating. And so she had sent those invites out. We had about 50 people there, and about a third of them were community members. But I think if you're interested in participating and being part of those formats, I think the easiest thing to do would probably be just to send me an email, and I can pass those on. We're going to have Lisa just retired. We have a new executive that'll be coming on. I don't know what his start date is yet, but I can start to pass those names along. The other thing we're getting ready to form is, well, maybe before I say that, I'll finish my thought. The visioning session wasn't the only thing that we did. You know, last year I did a community breakfast where we invited, I think, 25 or 30 members from the community to come. And we did just a broader kind of healthcare industry overview and update, kind of where do we see the industry going? How does this impact St. Charles? How does that lead to how we think about the world? And what do we see our main obligations as a health system being to the community? And so same kind of thing. We just tried to pick people from different groups, whether it was the sheriff or from the education board or the fire department or city council or whatever. We've hosted a couple different things. So if you want to be part of those, please let me know. We are going to form a group called the Redmond Advisory Group. Well, we've had one historically, and that's not just an opportunity for us, I think, to share our thinking with you guys and get feedback. It's an area where community members come and actually share their concerns and things they need and partnerships they need from the hospital. We had one a few, I would say maybe ended about a year and a half ago. It wasn't really well attended, and I don't know that we did a good job, I think, getting our agendas set. So our goal is to refresh that and kind of broaden the participation in that. So if that advisory group is also something that you would be interested in participating in, I would love to get people's feedback on that, and I can pass the info on and we can broaden out the invites.
Wonderful. Thank you, Aaron.
You're welcome. Sorry, that was a little long-winded answer there.
I guess I would just add to Josh's comment too. I think board representation from Redmond would be helpful too. And I know that's kind of been a sticky subject over the last few years and whatnot, but I think that having someone from Redmond or this community on the board of directors would be helpful.
Yeah, I know that information's gone to the board. That information's gone to Joe Sluka, who's the system CEO. It's a little above my pay grade at the hospital level. But I know when we did the community breakfast, you know, all the city council members were there. Ed Fitch was there, and we had a long dialogue around that. So yeah, they're absolutely aware of that desire.
Can I ask one more question on the, if we go with this transformation or this process, talk about staff movement, people that live in Redmond that perform these services. Are they going to maintain their jobs, keep their jobs, have to transfer to Bend, take new jobs here? What are we looking at from an overall employment standpoint?
No, those are good questions. So I think from the, if I just kind of think about each of those different elements, the rehab center, the growth of general surgery, the medical office building, those are really all adds to the community from a job perspective. It could mean that people want to move around. So if we were to move rehab there and double its size, we're going to need to add more positions to that department in order to handle double the patient load. So one thing it may mean is people are moving around. So a nurse today who works on a medical surgical floor at Redmond may apply to work in the rehab unit. So I imagine we're going to see some bumping around. There's actually some people who'd worked in rehab historically that work at Redmond and have expressed interest. but I don't see it really eliminating any jobs at Redmond. I see it growing the jobs there. The one area where we do see volume going from Redmond to Bend would be if we move forward with the orthopedic trauma service, but that's not enough volume to impact anybody's jobs. I mean, it's 4 cases a week. It's basically 1 OR day a week for 1 room. And I think the general surgery growth will more than offset that volume, if that makes sense. Likely what we will see is a number of people from Bend moving to Redmond to work there. Like anyone who works in rehab here today would end up working in Redmond in the future if we move the program.
I guess one more follow up to that, the air ambulance that flies out of Redmond probably wouldn't be seeing that as much in the future.
Yeah, it's an interesting question. So there are a number of trauma procedures that don't require orthopedics that happen at the hospital today. So somebody has appendicitis or some issue and they need to be airlifted into Redmond. That will continue. Most of those 4 orthopedic cases that happen at Redmond today, those people are either coming by ambulance to the ED or they're driving to the ED on their own. The complex crashes that generally, like a car accident that happens and requires airlift, those generally need to come to Bend today because they tend to have lots of multiple injuries, and it's not just orthopedics that need to be intervened. You need your number 1 trauma team here to help with that. And so those cases already tend to come to Bend today. So I'm not sure exactly how it would impact our flights in. I know one of the conversations has been there are a lot of general traumas that are done here at Bend that likely could and should be done at Redmond. So we are hoping to move some of those back. It's not unusual for us to have patients come in from John Day or Burns and fly into Bend when Redmond can provide those services. So I think part of our goals is to try to change some of those algorithms so those patients actually go to Redmond as opposed to coming to Bend. We have a facility at Redmond that's not utilized enough, and we have a facility at Bend that's overutilized, and is full. So we're hoping to balance that out to a greater degree.
Thank you very much.
No, you're welcome. It's a lot of moving parts, so I'm not exactly sure where we'll land, but again, I think part of my commitment after the Family Birthing Center was to say, look, we're going to just try to share all this stuff, our thinking with you as early as we can. It's going to be messy because we don't have everything quite figured out yet. That's kind of one of the prices or complexities of transparency, but at least everybody's hearing about it up front and there's no surprises.
This is Dick Keene. I'm a retired physician and served on the Oregon District Hospital board and transferred with that board to joining St. Charles. I was on the St. Charles Foundation for approximately 8 years. What I've seen in this period of time is a disturbing tendency for concentration of acute care in Bend and transferring the less profitable medical care in our area to outside areas. It is now focused on the health and welfare of the St. Charles system, whereas 20 years ago, the focus was on the welfare and care of the community. And I see this as continuing. Loss of maternity care to a community of in excess of 30,000 people was a disgrace. The proposition now that a hospital facility, which was at the expense of the Redmond community, is now destined to be either a single specialty facility or a rehab situation on the way to being an assisted living community. And I think this is very poor historical utilization of and opportunity for medical care in the community. And it's been at the behest of St. Charles. And I say this with all due respect to Sister Margaret. I all due respect to Jim Deagle, all due respect to a lot of the people who have been concerned about good care to the community, not good financial to St. Charles. I say this as a comment that disturbs me. It's heartfelt. I see the presentation that you've given today, and you've done a good job of it. But the focus is on what's going to be most economical and profitable for St. Charles as an organization. What is going to be best and most economical for our community? And I'm all in favor of the proposition that more Redmond community members get involved in the decision-making at St. Charles, because we're being ignored and the community is not being well served. And in spite of the fact that maternity nurses were transferred to surgery, now the surgery is going to be reduced. So the surgical nurses are going to be transferred over. I mean, you're reducing, regardless of how you want to spin it, you're reducing the acute care in the Redmond community. And I think it's a disgrace at the size of the community. And I'm eager to hear your response.
Well, I certainly appreciate that feedback. I got a couple of thoughts. I think one is, I wonder, if you guys would ever consider inviting me back. Maybe one of the things we could talk about is just where we see the industry going and why we need to make certain choices as a health system in order to sustain services over a long period of time while expanding access to care. So that we obviously didn't get a chance to cover that today, but I think that helps people understand, why do we use certain lenses to look at different situations and different problems? I think it provides really good context. I think most people recognize that healthcare is too expensive for people. I think one of the so I would argue, coming from a large health system, that St. Charles is not structured properly today to sustain itself in the long run. Most of the profitable services in the health system have been moved and are managed by independent healthcare groups. We don't have orthopedic surgeons. We don't have many of the services that are historically have been profitable, right? Those have been managed by outside independent groups. And a lot of what St. Charles has taken on is primary care, hospital-based services that are very expensive and tend to lose money. So part of what St. Charles needs to do is to restructure itself in a way where we make decisions that are good for patients, but allow us to be sustainable over the long run. And, the access issue to me, so the rehab problem, the fact that there's about, a couple hundred people a year that can't get service from us, that is a patient safety and an access problem to me. That is a quality issue. And that's an issue. That's the issue that I want to solve. Now, I could solve that at Bend. I could just invest and double that program at Bend, and I wouldn't get a lot of flack from the rehab nurses. But I want to try to invest in the Redmond community because I heard what the community told me when we closed the FBC. I heard the desire, and I can make that investment in the Redmond community. It's good for patients and it's good for Redmond. It creates more jobs. So to me, I feel like none of these are just unilateral one benefit. They actually have multiple benefits associated with them. The orthopedic trauma service, again, I have mixed feelings. The whole idea of the visioning session was to invest in Redmond and to make it thrive as part of a broader strategy for the region and how we provide care and access for people. The hard part is, again, when a year from now you're only going to only have one orthopedic surgeon in Redmond, it's hard to sustain a program there. And I don't know as an administrator that I have a lot of options available to me. I think that the medical office building investment, in my mind, and you would certainly recognize this as a former physician, to me, that's the foundation for building those clinical practices in the northern communities so that those patients in those communities can be served in those communities. But I think if physicians are going to practice and live in Bend and only come up and run clinic in Redmond in order to take their patients back to Bend, we're never going to see the Redmond community thrive. And so I think that to me is such an important investment. The cancer center investment there in Redmond doesn't generate us as a health system any more money. It's the same amount of money we would have just caring for patients today at Bend. That investment allows us to keep the patients who live in those communities today there, and it brings those economics to the community. It brings more jobs to the community. So again, I could just expand the cancer center here at Bend and continue to see those patients. It doesn't necessarily help the health system economically overall, but to me, it helps offset some of the travel that people have to do. It's a service that we can provide effectively in that community, and I want to try to do that. So I'm trying to balance all of those things as we think about it. I don't know that we'll hit the nail on the head perfectly, but I do think our goal is to try to check all those boxes, right? Can we provide better quality care for people? Can we improve access? Can we continue to invest in services that don't make money because we're able to manage our whole portfolio and our whole business? Can we sustain ourselves over the long run because we don't duplicate a bunch of services unnecessarily? It doesn't do us any good to have birthing services at 3 locations and have them all be underutilized. If I was to tell you in my forecast in 3 years, the hospital will be break even at best, that should be pretty alarming to the community. So I think most people know the economics in healthcare are very, very tough. So sustainability to me is a critical part of us being able to meet our mission, whether it's Redmond or Bend or Prineville or Lapine. We got to be able to keep going. And so to me, these things are all very much intertwined, and we're trying to make those choices that check as many of those boxes as we can. So sometimes it's going to mean that people aren't going to be happy with us. I don't like the way we handled the family birthing center discussion. I think we brought a lot of community members in, but it wasn't really publicized enough. I think we absolutely need to do a better job there. Was it the wrong decision? I don't know. I feel like we're providing a safer product that's more affordable. That feels okay to me. It doesn't mean people feel good about it, but hopefully I can make up some of that by bringing more business to Redmond and expanding services. So I'm certainly not trying to discount your feedback, but I don't know that it's as clear as no one's out to do harm to the community there. And I certainly hope you guys don't feel that way. But there are tough decisions for us to make as a health system. And maybe if we spend a little more time at a future meeting talking about some of that context, maybe it'll help a little bit and lighten some of our thinking. And you may or may not agree with it, and you may still have tough feedback for us, but at least we're having good dialogue around it. So I do appreciate the feedback on it. And again, I think part of the reason why we wanted to come out today is because of all the, I would call very tough feedback we got last go around.
Thank you very much.
Yes, thank you, Aaron. We appreciate your time. Yeah.
Again, I look forward to coming back. And again, if you want me to talk about healthcare economics, I'm more than happy to do it.
Definitely. Thank you.
Guys, thank you for your time today.
Thank you.
All right, so I'm going to wrap things up with the thought of the day. So, to accomplish great things, we must not only act, but also dream, not only plan, but also believe. So thank you everybody for joining us today. So board members, please stay on the call. If you're not a board member, you are welcome to join us, but not a requirement. So, okay.